Hi, and welcome to Radonc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria. I'm currently a fourth-year Radonc resident at the University of Pittsburgh, and today we will be starting a discussion on treatment of brain metastases, beginning with a talk on whole brain radiotherapy. Whole brain radiation has been around since at least the 1950s, and historically it was the primary method of treating cancer once it had metastasized to the brain, other than obviously receiving surgery. The advantages of whole brain radiation are that it bathes the entire brain, so it not just treats the macroscopic metastases that we can actually see on a CT scan or MRI, but also microscopic disease that may just be too small to be detected by our imaging modalities. The most common dose regimen for whole brain radiation is 30 gray in 10 fractions. I have also sometimes seen 20 gray in 5 fractions used for patients that have a very poor prognosis. The dose regimen is often just determined by institutional practice and the preference of the attending that you're working with. The other use for whole brain radiation, besides treating brain metastases that already exist, is something known as prophylactic cranial irradiation, or PCI. This is often seen in cases of small cell lung cancer, which has a very high likelihood of spreading to the brain. So oftentimes, patients with limited stage small cell lung cancer, even when they don't have brain metastases, might qualify for PCI, so whole brain radiation in the prophylactic setting, to prevent formation of brain metastases. And the dose for PCI is 25 gray in 10 fractions. We won't get into too much detail about PCI today. Our focus for this particular talk is just treatment of brain metastases. So we'll start by talking a little bit about brain metastases, how they form, where they go, how they're diagnosed. Then we'll get a little bit into the treatment options and actual evidence for whole brain radiation, talking about the clinical trials that inform our practice. And we'll end by talking a little bit about hippocampal avoidance and also whole brain radiation technique. Let's start by discussing the basics of brain metastases. If anyone ever asks you what is the most common intracranial tumor in adults, the answer is brain metastases. So in adults, it's actually more common from some other type of cancer to metastasize to the brain than it is to develop a primary brain tumor. So brain mets account for over 50% of brain tumors in adults, and 20 to 40% of all cancer patients eventually develop intracranial metastases. And if you think about why that number is so high, it kind of makes sense. We now have much better detection of brain mets due to advanced imaging modalities such as MRI. And we also have improved cancer therapies that lead to better survival of patients even when they have metastatic cancer. Another thing to realize is that when patients develop brain metastases, more commonly than not, so 80% of the time, they're going to have multiple brain mets. It's actually pretty rare to see a cancer patient with just one brain met. In terms of the most common primary tumors that are responsible for brain mets, again, common things are common. So in adults, it's things like lung cancer, breast cancer, colorectal cancer. Other things are renal cell and melanoma. In children, it's things like sarcomas, neuroblastomas, and germ cell tumors. In terms of pathogenesis, the most common mechanism of metastasis to the brain is via hematogenous spread. So the cancer spreads to the brain through the bloodstream. Metastases are usually located at the gray-white matter junction, and the reason is because the cancer travels through the blood vessels, and it's at the gray-white matter junction that the blood vessels decrease in diameter, thereby trapping clumps of tumor cells right at that gray-white matter junction. For the same reason, brain mets are also more common in the terminal watershed areas of arterial circulation, just because the diameter of those arteries narrows and the tumor cells get trapped there. In terms of distribution of brain mets through the different areas of the brain, it makes sense that it kind of follows the weight and blood flow within each area. So the cerebral hemispheres take up the most space in our brain, and so about 80% of the time, brain mets are going to be located in the cerebral hemispheres. Then about 15% of the time, they end up in the cerebellum, and 5% of the time, they end up in the brainstem. When patients present with brain mets, they usually complain of symptoms that are related to the edema associated with their tumor. So just to show you an example, the picture that we have on this slide shows an axial section of a contrast-enhanced T1 weighted MRI. And you can see that the patient has a ring-enhancing tumor located in their left parietal lobe. And all that dark gray material that's anterior to the tumor is edema related to the tumor. And so you can see that the degree of edema far outweighs the size of the tumor itself. And so usually it is edema that leads to the patient's symptoms. And what are they? So very commonly, patients might complain of headache. If the tumor is located in the motor cortex, for example, they may have focal neurologic dysfunction. They may have cognitive dysfunction, such as mood or personality changes, especially if it's located in the frontal lobe. They might present with seizures or stroke. Less commonly, brain tumors can present with hemorrhage. The most common pathologies that lead to hemorrhage are things like melanoma and renal cell cancer. If the tumor is located in such a way that it's blocking the ventricles and obstructing CSF flow, it might lead to obstructive hydrocephalus. And again, rarely it can lead to tumor embolization as well. Workup of brain metastases is fairly straightforward. Remember, we always start with a full history and physical. In this case, we'll probably focus on their neurologic exam. And then for imaging, we typically first proceed by getting a CT head with and without contrast just to rule out a brain bleed. And then we will obtain an MRI brain with and without contrast, which is really the gold standard for diagnosing brain metastases. On a T1 pre-contrast image, the brain met will probably appear iso to hypointense, and it might only have a high intrinsic signal if it's hemorrhagic. On a T1C or a T1 post-contrast image, now the tumor is going to start taking up contrast and appear bright or hyperintense just because it's highly vascular. So it might appear as a uniform, punctate, or ring-enhancing lesion, but it's going to be hyperintense most commonly. And then finally, we have the T2 sequence. So a T2 flare is a fluid attenuated inversion recovery sequence, and basically it just suppresses the intrinsic brightness from the CSF within the ventricles, and it makes it easier to see the peritumoral edema. Remember that T2 enhances H2O, so water is going to be bright, and this sequence is going to be really good at looking at the edema surrounding the tumor. Now, beyond imaging, remember, it's always important to have pathology. We have to establish a tissue diagnosis of cancer before we come in with our anti-cancer treatments. So if a patient has a known history of a metastatic cancer and they come in with neurologic symptoms and now they have new imaging confirming brain mets, then you probably have all the information you need to proceed with radiation or whatever treatment you're going to intervene with. However, if a patient has a new neurologic deficit and no established history of malignancy, then we need to pursue a full workup, get full body imaging, and figure out where the cancer is coming from. And then once we have a good target to biopsy, we might get pathology from either another metastatic site or maximal safe resection of the brain tumor. But remember that pathology is paramount and we need to establish a tissue diagnosis of cancer. I think it helps to learn the different sequences of MRIs by seeing examples. And so just really quickly on this slide, we have 3 different axial images of MRIs. We have a T1, a T2, and a T1 post-contrast sequence. So in the T1 sequence, we see an iso-intense lesion, or probably a hypo-intense lesion, in the right frontal lobe. On the T2, the lesion appears iso-intense, and we see that bright hyper-intense signal surrounding the lesion. That is indicative of the peritumoral edema. And then finally on the T1 post-contrast, we see that the tumor is avidly taking up contrast, it almost uniformly so, and it is very much hyper-intense, contrast enhancing. The last thing that we'll talk about when it comes to brain metastases is that they are not always, individual lesions kind of spotted throughout the brain. In some cases, the cancer can actually invade into the cerebrospinal fluid and actually attach onto the meninges. And when this happens, it is a condition known as leptomeningeal carcinomatosis. And we know that the meninges wraps around the brain and also the entire spinal cord. So leptomeningeal disease can manifest not just in the brain, but also all along the spine. And it can have some very nasty symptoms associated with it. So pain, seizures, patients can feel very nauseous and start to, have emesis. They might be lightheaded, weak, ataxic, incontinent with sensory abnormalities. And they might have cranial nerve deficits if the cancer starts to creep along those cranial nerve roots. And this would be visualized on an MRI at the level of the brainstem. In terms of diagnosis, on MRI, we can see nodular meningeal tumor, thickening of the meninges, and strong contrast enhancement along the meninges and along those cranial nerve roots if they're involved. And then we can also diagnose this based on the CSF, looking at their cytology, if they have increased opening pressure, leukocytes, or elevated protein. Leptomeningeal carcinomatosis usually occurs in very advanced cancer, and it is a terrible prognostic indicator, unfortunately. These patients typically do very poorly. That was a fairly grim note. So let's talk about what we can actually do for these patients. How do we treat brain metastases? As with any palliative situation, our first measure of management for patients with brain metastases is supportive care. So if they have seizures, give them seizure medication. If they have pain, give them pain medication. If they have nausea, treat that. And then we talked about how a lot of the time their symptoms are related to the edema surrounding the tumor. And so the best treatment for all that swelling and inflammation is steroids. And steroids have actually been shown to improve symptoms in the majority of patients within just a couple of days. The dose of steroids that we prescribe is very similar to what we talked about for cord compression. So you can prescribe IV dexamethasone 10 milligrams as a loading dose, followed by 4 milligrams every 6 hours. And then we can switch to oral and initiate the taper once we've initiated their anti-tumor treatment. Now, with steroids, you always have to give a PPI for GI prophylaxis and manage the patient's hyperglycemia if it happens. And always counsel them on all the different side effects of steroids, especially if patients have a chronic history of brain metastasis or are on steroids for prolonged periods of time. That's when we really start to see the fat redistribution and the Cushing syndrome and things like that. So it's really important to counsel them. Once we have stabilized the patient, we can think about how we want to go about treating their brain metastases. And the main options for treating brain metastases include surgery, stereotactic radiosurgery, whole brain radiation therapy, or some combination of all of these. And they all have their own advantages and disadvantages. So surgery is advantageous because if it's a large tumor causing significant mass effect, we can just scoop it out, and it can give us the histology if we don't have that established. Stereotactic radiosurgery involves treating just the area of tumor in a very high ablative dose given in just 1 to 5 fractions, and this can be combined with surgery to improve local control or used alone to treat small tumors that are not surgically accessible. Whole brain radiation is very advantageous when we're talking about treating multiple tumors or tumors that are encompassing a very high volume of disease, or if the patient has leptomeningeal disease. And again, none of these modalities have to be used in isolation. They can all be combined. Even all 3 of them can be combined. So depending on the patient, depending on the clinical scenario, it can be kind of a choose your own adventure of how to treat brain metastases. In the course of this lecture and the next talk, which will be focused solely on SRS, we'll kind of unravel the mystery, talk about the evidence, and hopefully give you a better idea of when we choose to pursue which type of modality. Anytime we're making a decision about which treatment to pursue for our patients, there are two things that we need to take into account. So, number one is the patient's disease status overall, and number two, the patient themselves and how well they can tolerate any given treatment. There are some tools that have been created to help prognosticate for patients with brain metastases. These tools are prognostic indicators. So, in other words, they help us predict the patient's prognosis or how long they have to live. These are just estimates, but they take into account the same two factors that we just talked about. So, number one, the patient's overall disease status, and number two, how well the patient themselves is doing. Another word for this is performance status. And performance status is hugely important in oncologic care. It's really important to be able to kind of on a metric scale, just as an indicator to the rest of the care team, have a way of communicating how well the patient is doing. So there are two grading scales that you should be familiar with, including the Karnofsky and the ECOG performance scales. So I have a table here listed for your reference. Remember that Karnofsky 100 and ECOG 0 are the same, and they mean that the patient is fully active, able to carry out all their pre-disease activities without any restrictions. A Karnofsky of 70% is equivalent to an ECOG of 2, where the patient is ambulatory and able to take care of themselves, but not actually able to carry out any work. So those are good numbers to kind of just know and be able to communicate to the team where the patient is and how they are doing. Performance status was very important in the very first prognostic tool, which came out in 1997, created by the RTOG. The RTOG performed what is known as a recursive partitioning analysis, or RPA, to create 3 different classes of patients with brain metastases and correlated these to different median overall survivals, or at least predicted survivals. So RPA class 1 was the highest median survival. These patients had a Karnofsky performance status of 70% or higher, age less than 65, and a primary tumor that was controlled with no extracranial metastases. Their predicted median survival was 7.1 months. For patients in RPA class 2 that had a Karnofsky performance status of 70% or higher, an age greater than 65, or an uncontrolled primary with present extracranial metastases had a lower median survival at 4.2 months. And finally, patients with a Karnofsky performance status less than 70%, regardless of their age or extent of extracranial disease, had a median survival predicted at 2.3 months. And so the 3 factors that predicted survival in the RTOG RPA classification status were Karnofsky performance status, age, and extent of primary disease. And remember that all patients with a Karnofsky performance status less than 70 fell into class 3 with the lowest predicted median survival at 2.3 months. In 2008, a slightly modified version of the RPA came out, and this was known as the GPA, or the Graded Prognostic Assessment. The GPA was different than the RPA because now we were assigning scores to different criteria. So we still care about the patient's age, the Karnofsky performance status, and presence of extracranial metastases. But now, in addition, we also care about the number of CNS metastases. So you can see that depending on the patient's age, performance status, number of METs, and presence of extracranial METs, each category gets assigned a score, and we add up these scores to predict the patient's median survival. So we don't have to go through this in too much detail, but just know that the GPA differed from the RPA because we now also care about the number of CNS metastases, in addition to everything else we talked about for RPA. We now actually have an even more modern tool known as the diagnosis-specific GPA. So this is something that you can look up online for your patients at brainmetgpa.com if you're interested. But this is a tool that has been created based on multi-institutional databases with multivariate analysis of patients with newly diagnosed brain metastases, and there are specific prognostication schemes that are diagnosis specific. So you can look up for your patient depending on what their pathology is. So all those tools, the RPA, the GPA, they're very important to know for board exam purposes. And I think what's more important is the principles that underlie our approach to treatment. And really this applies to any disease site, whether we're dealing with a curative or a palliative situation. But it's really important to know the patient's disease status, and it's really important to know what the patient looks like. So that's where age and performance status come into play. So very important to keep in mind, and that drastically affects how we think about treating our patients. Let's move on now and talk about some evidence for whole brain radiation. Just to give some context, in a lot of trials that we talk about, these are older trials that occurred in an era where whole brain radiotherapy was really the only option from a radiation perspective. Now that we have stereotactic radiosurgery as an option to treat brain metastases, our thinking has changed drastically in terms of how we approach these patients. Nowadays, whole brain radiation alone is kind of the last resort for treating brain metastases. We resort to whole brain radiation if we're dealing with patients that are not eligible for stereotactic radiosurgery or regular surgery, either because they have a poor performance status or because they have too many or too large of a volume of metastases. We also consider whole brain radiation alone in patients with leptomeningeal disease, which we talked about as a very poor prognostic indicator. Whole brain radiation can often be used as an adjunct either after surgery or stereotactic radiosurgery for brain metastases as well. But again, this is typically as a last resort in a situation where the disease is progressing and it's too much volume to be controlled by SRS or surgery. One of the earliest trials that we have showing the benefit of radiation therapy in treatment of brain metastases came out of Memorial Sloan Kettering in 1980. And in this trial, they had about 180 patients treated with steroids plus whole brain radiation in the late 70s. When they looked at these patients, they found that 74% had neurologic improvement, with only 6% of them having deterioration. And they found that 60% of the time, the patients died due to advancing systemic disease in the setting of actually stable or improved neurologic function. So this study showed that most patients with brain metastases derived at least some benefit from radiation, either stabilization or improvement in their neurologic condition. And when patients died, it was most often from systemic disease and not CNS disease that limited their length of life. The next study, the PATCHEL-1 study, is very important to know. This study came out in 1990 and looked at adding surgery to whole brain radiation. So they took 48 patients with a single brain metastasis and randomized them to receive either surgical resection of the brain tumor followed by whole brain radiation, or just a needle biopsy followed by whole brain radiation. And what they found is that patients had drastically improved outcomes with the addition of surgery prior to whole brain radiation. They had an improvement in their rates of recurrence, 20% versus 52%. They had a significant improvement in overall survival, 40 weeks versus 15 weeks. And in addition, they had improved maintenance of their performance status. So the PATCHEL-1 study showed us that surgery plus whole brain radiation for a solitary brain metastasis improved overall survival, reduced local recurrence, and improved quality of life and performance status. So the PATCHEL-1 study showed us that adding surgery to whole brain radiation improved local control and overall survival. The next logical question is, we know that surgery improves outcomes when added to radiation, but do we really need that radiation after surgery? And so this question was answered by PATCHEL-2, which was published in 1998. In the PATCHEL-2 trial, 97 patients with a single brain metastasis after surgical resection were randomized to postoperative whole brain radiation versus no further treatment, and both groups of patients did receive steroids. What they found is that the post-op whole brain radiation group had an improved rate of recurrence and neurologic outcome, but no improvement in overall survival. So the patients receiving post-op radiation had decreased rate of recurrence at both the site of the original metastasis as well as all other sites in the brain. They were also less likely to die of neurologic causes. However, there was no significant difference in overall survival or the time that these patients were functionally dependent. So PATCHEL-2 showed us that post-op radiation added to surgery improves local control and neurologic death, but not overall survival. Another more modern study to know is the QUARTZ study. So this was a trial of patients with non-small cell lung cancer who had one or more brain metastasis that was unsuitable for surgery or stereotactic radiosurgery. And these patients were randomized to receive either whole brain radiation plus steroid or supportive care alone, which also included steroids. What they found is that most of the patients in the study were fairly poor performance status and poor prognostic status. So most of them were RPA class 2 or RPA class 3. There was no significant difference in the overall survival or the quality of life between the groups treated with whole brain radiation versus supportive care alone. The median survival in both groups was 2 months. Now, keep in mind that this study was limited to patients with non-small cell lung cancer, and also keep in mind that they had very poor performance status to begin with overall. These situations can be very, very tricky when you're actually consulted on patients in the hospital, but the QUARTZ study is one where the data kind of supports hospice if the patient does have a very limited life expectancy. And we did mention earlier that 30 gray in 10 fraction is really established as the most common whole brain radiation treatment regimen. That comes from some older RTOG trials. The other common regimen to know is 20 gray in 5 fractions, which offers just as effective palliation as longer schedules. But this is often reserved for patients with much poorer performance status as it's thought to be less durable. So that was quite a bit of evidence. But we've established now that whole brain radiation improves neurologic outcomes in patients with brain metastases. Adding surgery to whole brain radiation improves local control and overall survival. And adding whole brain radiation on top of surgery helps improve local control and distant brain control. Based on the QUARTZ trial for patients with non-small cell lung cancer, maybe if patients have very, very poor performance status, whole brain radiation isn't too much more beneficial than just supportive care alone. But overall, it seems like whole brain radiation definitely provides some type of neurologic benefit. So why not just do it for everybody? Obviously, the answer is because whole brain radiation is associated with a long list of toxicities, both acute as well as late. The acute toxicities are listed there, and we have to counsel patients on them. They're listed here for your review, but they're not so bad, and eventually patients will get past them. The late toxicities, such as cataracts, are obviously things that we can deal with. However, the biggest late toxicity that we really worry about when we're treating with whole brain radiation is the neurocognitive toxicity. Whole brain radiation, around 4 to 6 months after treatment, can lead to neurocognitive deficits such as short-term memory loss, brain atrophy, dementia, and these can be really, really damaging to the patient's quality of life. And so if patients have a predictive survival of at least 4 to 6 months, then we try to spare them that deficit of neurocognitive function. And we do this by either avoiding whole brain radiation in favor of something like surgery or stereotactic radiation, or if they cannot get these treatments, then we try to spare their memory centers using whole brain radiation with a technique known as hippocampal avoidance, and we may or may not add the drug memantine. So one of the techniques that's been tried to kind of help ameliorate some of those neurocognitive effects of whole brain radiation is adding a drug known as memantine. Memantine is an NMDA receptor antagonist, and the idea is that excessive NMDA stimulation leads to excitotoxicity. So by antagonizing the receptor, maybe we can have a neuroprotective effect. And in fact, memantine has shown to have a neuroprotective effect in preclinical models for vascular dementia. So RTOG 0614 was a clinical trial that randomized patients undergoing whole brain radiation to receive either memantine versus placebo. Memantine had to be titrated up to a maximum dose of 10 milligrams BID over 4 weeks, and then it was continued for 24 weeks. Keep in mind, memantine can affect kidney function, and so we have to monitor the patient's creatinine clearance when they're on this drug. When they looked at the results, they found that the patients that were treated with memantine had less of a decline in delayed recall. Unfortunately, their primary endpoint did not reach significance. However, the memantine arm had a slightly longer time to cognitive decline, and the memantine arm was superior for executive function, processing speed, and delayed recognition. There was no difference in survival or toxicity related to memantine. So, in other words, RTOG 0614 showed that memantine actually had a benefit in terms of cognitive decline, but the results did not reach significance. The other technique that has been tried to ameliorate those neurocognitive effects of whole brain radiation is a technique of whole brain radiation known as hippocampal avoidance, or HAWBRT. This was first studied in a phase 2 trial called RTOG 0933, and the trial included patients with brain metastases located at least 5 millimeters away from the hippocampus. In the trial, they drew out the hippocampus and created a hippocampal avoidance structure, and they restrained that structure to the following dose constraints. So the D100% had to be less than 9 gray, the D max had to be less than 16 gray, and the mean dose had to be less than 10 gray. And what they found was that the mean relative decline in delayed recall at 4 months was 7%. And this was much better than 30%, which was the historical control of decline and delayed recall. So again, this was a phase 2 trial sort of showing the feasibility and improved delayed recall with hippocampal avoidance. The hippocampal avoidance technique was then tested in a phase 3 randomized trial, which was published in 2020. The trial was run by the NRG, and it was called NRG-CC001. So in this phase 3 trial, they also added memantine because we saw from that prior RTOG trial that memantine had shown a benefit. And so they compared the following arms, either whole brain radiation plus memantine or whole brain radiation with hippocampal avoidance plus memantine. What they found is that hippocampal avoidance plus memantine dramatically improved the deterioration in executive function at 4 months and total recall and delayed recognition at 6 months. There was no difference in the cognitive outcomes when they looked at the 2-month results. So this study shows that hippocampal avoidance plus memantine added to whole brain radiation improves cognitive outcomes at 4 to 6 months. When we talked about side effects, that we actually don't expect to see the neurocognitive decline until around 4 to 6 months. So if the patient that we're dealing with doesn't have an expected overall survival of longer than 4 months, they probably won't derive a benefit from hippocampal avoidance. However, if we do expect them to live that long, then we should strongly consider hippocampal avoidance plus memantine if possible. So hopefully you've gotten the gist by now. When we're dealing with whole brain, with brain metastases, we generally try to treat with either surgery or stereotactic radiosurgery or some combination of the two. If this is not possible, then we try for hippocampal avoidance whole brain radiation to spare that neurocognitive decline. And if avoiding the hippocampus is not possible, that is really when we resort to standard 3D whole brain radiation. I'd like to take a minute now just to talk about some of the techniques with standard whole brain and hippocampal avoidance whole brain, and then we will wrap up. I wanted to start by showing you the standard 2D approach that's used for whole brain radiation with what is known as a traditional German helmet field. So in this situation, we're treating with two opposed lateral fields. So one such field you can see drawn on the left side of the patient, and imagine an identical field coming in from the right side of the patient. Our borders are around 2 centimeters on all sides except for inferiorly, where we just try to cover the base of the skull with a 1 centimeter margin. We try to shield the lens, we try to shield the upper airway, but we're really not using too many fancy techniques here. This is kind of the traditional German helmet field. Nowadays, with CT-based planning, we're still using opposed laterals, but we can start to use some other fancier techniques, such as bringing in MLCs to better spare the scalp and better shield the lenses and the facial structures. We might also add some wedges or field-in-field techniques to our opposed laterals just to help improve the dose homogeneity of our plan. When it comes to hippocampal avoidance whole brain radiation, we're no longer using 2D or 3D methods. We're actually using IMRT planning. So this planning is a lot more complicated. But when we're doing these plans, in addition to contouring the brain, we have to contour the hippocampal avoidance structure. So we actually don't contour the entire hippocampus. We really focus on the subgranular zone, which is where adult neurogenesis occurs. So I'm not going to go through this in great detail, but there is a very nice contouring guideline available online, and these images are taken from that guideline. But it walks slice by slice through an MRI scan and shows us how to actually contour the hippocampal avoidance structure with a 5 millimeter margin. These are just some additional images from that guideline showing the individual slice-by-slice contours of that subgranular zone of the hippocampus. Once this is contoured, we actually add an additional 5 millimeter margin, and that becomes our hippocampal avoidance structure. And then finally, these are just some dose constraints for your reference, things to keep in mind when you're evaluating a whole brain radiation plan. So typically, we like our coverage to be 95-95. So we like the volume of the brain receiving 95% of the dose to be at least 95%. And then we also pay a lot of attention to the hot spots. We try to keep a maximum hotspot of less than 110%. In terms of organs at risk, in palliative settings, it's often kind of those organs get what they get. Ideally, we try to keep the maximum dose to the lens less than 6 to 8 gray. A dose constraint I've seen for the parotid glands is a V20 gray less than 47%. And then the hippocampus, we kind of talked about the dose constraints from the RTOG trial, but D100% less than 9 gray, the maximum dose less than 16 gray, and the mean dose less than 10 gray. There are some additional dose constraints from NRG CC001, which are also listed there. So deep breath, because that was a ton of information about whole brain radiation. Hopefully, through this talk, you had a good opportunity to either learn or review some of the basics about brain metastases and their pathogenesis. Hopefully, you kind of understand the basic principles that help guide our treatment decision-making. And specifically, when it comes to whole brain radiation, the most important trials to remember are the Patchel trials. So remember that Patchel 1 showed that surgery added to whole brain radiation improves overall survival. And Patchel 2 showed us that adding whole brain radiation to surgery improves local control and neurologic death, but not overall survival. The most common dose regimen that we use for whole brain radiation is 30 gray in 10 fractions. I've also seen 20 gray in 5 fractions for patients with very poor performance status. And remember, we talked about surgery and SRS kind of being the more preferred treatment regimens in this day and age. And if we are going to do whole brain radiation, we try more than anything to do whole brain with hippocampal avoidance if and when possible. That was definitely a long one, but hopefully it was helpful to you. Thank you so much for listening.